ready to get started, and we can jump right in.
Great. Wanapa Damras, you let us know when we're a quorum, and then I'll introduce Coulter and kind of some of our objectives of how we think enhancing and enriching today's experience would go.
We are ready, Prof.
Thank you so much. So good morning, everybody. And Coulter and I are truly appreciative of the opportunity to share some of our cases today with the greater BDMS community. We have two cases, and Coulter and I thought it would be best if we present the case as it unfolded and as our team encountered this case. The first case was Coulter and one of my colleagues. The second case was Coulter and myself. And so we are going to pause at several moments, and Coulter will prompt us to engage participants and ask what somebody might do at that point as the case unfolded throughout the afternoon and evening. So I believe everybody has met Coulter before. The partnership with BDMS and OHSU heavily involves our interventional fellow, and that's true during our monthly visits, but also during our exchange program. And so, Coulter, thank you so much for your participation and engagement with our BDMS community.
Thank you,
Absolutely.
Dr. Coulter.
Yeah, thank you everyone for joining in on the call. It's a pleasure to finally be able to present in person. I think the first presentation in August, my son was being born, and then the second one, I was taking my cardiology board exam. So finally, I get to meet all of you. So thank you so much for your time. So we'll jump right in. As Dr. Sigaral mentioned, we'll stop at a few points during the presentation and get your thoughts kind of as the case unfolds. So our first case is a case of a 65-year-old woman who was admitted for an elective cerebral aneurysm clip. The surgery was being done here at OHSU in our operating room. The surgery was going well until the patient suddenly became tachycardic and hypotensive with ST depressions noted on the cardiac monitor. Code STEMI was activated to the operating room. This is a representative rhythm strip from the operating room monitor. The patient's initial baseline rhythm was normal sinus rhythm. When we arrived to the room, the patient's blood pressure was 60 systolic over 40s diastolic. This was despite multiple fluid boluses. Several liters were administered. The patient was started on multiple vasopressors, norepinephrine, epinephrine, and vasopressin, all at high doses. As we entered the room, the anesthesiologist was placing a central line, and the neurosurgical team was performing an expedited closure of the scalp. So we'll pause here just for a moment. And as we walked into the operating room, it was kind of our job to do a quick assessment and figure out the next steps. I'm curious to hear what the audience's thoughts would be at this point during the case.
Yeah, obviously, I want to see 12 leads EKG, and if you can perform a quick look bedside echo to see any damaging of the regional myocardial function, because it should be something like a cardiac new cardiac disease. It may be involved or not involved by the neurosurgery. I don't know the hemodynamics of this cerebral clipping. Is there any bleeding supervene on the surgical field?
Yeah, those are all really good thoughts. So as far as the surgery, it's relatively little blood loss, both planned and what had actually happened. There wasn't much blood loss during the procedure. Um, and so that was our, again, we were in full agreement with your suggestions. Um, so this is the 12 lead ECG. This was right after a bolus of fluid, so the heart rate did slow down slightly. This took a few minutes for the team, the operating room team, to get the 12 lead ECG monitor in the operating room. But this is the ECG that we were given. Does anyone have any thoughts on what we're seeing here? If you're
You're
speaking,
on
I'm sorry,
mute.
I'm
You're muted,
unable to hear
Damros.
Sorry. I see the SC segment elevation in AVR and diffuse SC segment depression from V2 to V6. And that should be, I think, in my mind, because BP is only 60/40, it should be something like in left main.
So yeah, it's as I look at this EKG, the first thought to me is it's an ugly EKG, and whatever is going on is threatening this patient's well-being, and will rapidly need to determine the cause and implement some corrective actions. And this almost looks like a post-code electrocardiogram, where somebody has arrested and, they're somewhere between PEA and a chemical code.
How long does it take to restore hemodynamics? More than 30 minutes or 15 minutes after you give the norepinephrine?
That's a good question. So the patient became tachycardic and hypotensive near the end of the case and had received multiple liters of fluids. And the anesthesia team had stacked on norepinephrine, epinephrine, and vasopressin. And throughout all of that, the blood pressure was essentially 60 systolic over 40 diastolic without much change one way or another. The heart rate was this irregular rhythm. The heart rate was mostly in the 130 range, kind of on the top end. After fluid boluses, it would come down to just over 100, but then come right back to 130 beats a minute. But the blood pressure essentially was unchanged despite the multiple pressors.
So
What is
stage
the
D.
immediate CVP line pressure? The immediate
So
CV line pressure.
yeah, so good question. So fortunately, the team had a cardiac anesthesiologist performing the case. They quickly put in a central line, but they had not connected to the transducer yet. So we didn't have a central pressure. They were mostly worried about trying to get the pressors in through the central line.
So we would say,
probably put the PA catheter just
so
to make sure that
refractory
we do not miss.
refractory cardiogenic shock despite interventions with a electrocardiogram that looks profoundly ischemic, like a postcode. And, if one were to simply go by probabilities, elevation in AVR and ST segment depressions throughout would suggest either multivessel disease plus minus osteal LAD/left main, or that and a profound metabolic abnormality, or a profound metabolic abnormality. But it's ischemic till proven otherwise without understanding the etiology of the ischemia.
Yeah, so those are all excellent points. So we mentioned trying to get hemodynamics. It was brought up to get an ultrasound to try to figure out if there's any wall motion abnormalities that were present. As we entered the room and were able to get an assessment of the patient and the situation, we got a 12-lead ECG, compared it to baseline. The baseline was sinus rhythm. And in the setting of new atrial fibrillation with RVR, my suggestion to the team initially was to perform a synchronized cardioversion to see if we could get the patient back into normal sinus rhythm, improve the heart rate, and see if that would improve the hemodynamics. Understanding that the patient was cycling into extremis and was on multiple vasoactive agents, which may not allow for the patient to be successfully cardioverted. And so for that, in that setting, 200 joules of synchronized cardioversion was administered one time and was unsuccessful. My thought was to only do the single cardioversion rather than continue to perform defibrillation to try to get the patient back into sinus rather than stunning the myocardium with multiple shocks, knowing that they were on high doses of norepinephrine, epinephrine, and vasopressin. So the cardioversion, unfortunately, was unsuccessful. We didn't bolus amiodarone at the time because of the hypotension and knowing that the carrier for amiodarone can sometimes drop the blood pressure. We deferred that decision until we could get more information. So I mentioned we were fortunate to have a cardiac anesthesiologist performing the procedure or assisting with the surgery. They were able to get the echocardiogram station into the operating room, and they were able to insert a TEE probe. We didn't get specific measurements, but we did get a gross subjective assessment of the LV function, and I'll show some other images of the valves as well. And so here is a short axis view of the mid-left ventricle. You can also see some of the right ventricle in this view. So as we're looking at this, there appears to be, at least moderate concentric hypertrophy with a hyperdynamic left ventricle. In this single view that we're seeing, there are not any obvious wall motion abnormalities, but in the setting of a hyperdynamic LV and not having more images, it's hard to get a full assessment of wall motion abnormalities.
I saw something on the right side, right atrium, or either right ventricle.
Timers are active.
I don't know how long does the patient lie down on the operating bed. For the other cause may be massive pulmonary embolism.
Yes, that's a good point. So pulmonary embolism is certainly on the differential diagnosis for this patient. We can see part of the right ventricle in this view, but we can't see it fully. And so I'll go to a different view here. So this is more of a 4-chamber, more of a 5-chamber view, if you will. I didn't include all of the views that we had, but it looked like the right ventricle was maybe mild to moderately dilated, and the RV function was maybe mildly reduced, but it didn't look large and blown out, if you will, in terms of a massive PE that was leading to right ventricular failure. But you can see here the mitral valve separating the left atrium on the top and left ventricle on the bottom with color flow. Does anyone have any thoughts on what we're seeing in just this 4/5 chamber view? With regard to the, looks like we have some maybe severe mitral regurgitation here.
It's really an interesting sequence, right? We have an ambulatory patient who, during a clipping procedure, develops hemodynamic embarrassment and doesn't appear to have a regional wall motion abnormality and has MR. And it's hard to think about this MR as being secondary to an increase in afterload from the medications that are being used to support the patient's blood pressure. And this is MR with a systolic pressure of 60. And I'm a bit befuddled about why now. I mean, if we think about clipping, you know, if anything, you can develop acute vasoplegia with a drop in SVR, or you can develop a acute Takotsubo type experience with precordial Welland T waves and a Takotsubo environment. This also, to me, doesn't look iatrogenic. That is, that inadvertently somebody gave a whopping dose of a vasoactive medicine with a blood pressure that went through the roof, and consequent functional MR in the setting of profound systolic hypertension. And I must admit, based on that electrocardiogram, it's not what I expected to see.
Dr. Sikarua, could
Yes, sir.
you mention on the tip of the mitral valve leaflet? I see that there is something like this. It's not near normal. It might be some either prolapse or rupture of some valve or some chorditendiny. If you look at on the on the
Posterior leaflet.
the tip of the leaflet,
Yes, sir.
it's not normal.
I agree with you. So, Coulter, what was the team thinking?
Yeah, so
And that's a
at
great
this point,
view right there.
yep. Yeah, so at this point, we have, kind of as you had summarized, a patient who was doing reasonably well until the surgical procedure that, as far as we could tell, wouldn't have had any specific reason to cause hemodynamic alteration. We have new AFib with RVR and severe MR despite systemic hypotension. So at this point in the procedure, with a little bit of concentric left ventricular hypertrophy and severe MR, there was some concern that perhaps there was maybe some hypertrophic cardiomyopathy and some left ventricular outflow tract obstruction that could be occurring. On the images that we had during the transesophageal echo in the operating room, the gradient was really only 15, so that wasn't really providing us a lot of support for that hypothesis at the time. And so, in the absence of wall motion abnormalities, despite that ECG,
by the way,
our
I have to talk
suspicion for sorry about that. Our suspicion for ACS was a little bit lower, but still on the differential. And so we thought that, in the setting of a patient who has progressed into cardiovascular collapse, so cardiogenic shock stage DE, that we would bring the patient to the cardiac catheterization lab to get some more information. You can also see here the aortic valve is moving sufficiently, so severe AS is not an issue at this point. Was there any other thoughts or anything else that anyone would recommend at this point in the patient's course?
I will turn off the color of the inflow and outflow on the mitral valve and see exactly at the mitral valve morphology to see that is there any prolapse or perforation or rupture of chorditendinae. Because when you have inflow and outflow, it's obstruct the view, the correct view of the mitral morphology.
Yeah, those are very good points. So we did have 2D views. I didn't include them in this presentation, but there was no significant flail or perforation that we could see on TE at the time. Those are good thoughts. So to get some more information, we brought the patient to the cardiac catheterization lab. Given that ECG, we wanted to make sure that we weren't missing an ACS event. So we went in right femoral artery, ultrasound guidance, went in with diagnostic catheters. This is a JL35. You can see in our caudal view here that we have the left, so moderate caliper left main, which gives rise to a left anterior descending, and a left circumflex artery, which is seen better in this caudal view. There's probably some mild to moderate diffuse disease throughout the circumflex artery, which comes to rise and give off a large OM1 branch with a superior and inferior branch. No severe focal disease of the left circumflex before it courses on into a smaller atrioventricular groove circumflex. In this caudal view, I'll show you a little bit different view, but there's at least moderate to severe proximal left anterior descending stenosis. So here's a cranial view. Here you can see a little bit better. The proximal left anterior descending artery is probably about 80% stenosed, and then gives rise to a small to moderate size first diagonal branch, which is approximately 95% occluded at its ostium. And then there's mild diffuse disease throughout the LAD that courses to the apex.
There's also myocardial bridging on the mid-LAD too.
Correct. Yep. That's a good idea.
I prefer to define this lesion as 76 to 90% stenosis by Gensini score. And if you multiply by the location is 2.5, then this should be around, nearly 30 the score from the Gensini.
Yes, so I agree. I would characterize this as a severe stenosis in the proximal LAD.
And this is being done on epi, norepi?
Correct, yes. So this is norepinephrine, epinephrine, and vasopressin at the time.
It's always interesting when we cath people, and I assume that lactate is elevated here given the duration, but I think it's, we all know that under stressors, whether it is cold or metabolic abnormalities or hypoxemia, that areas of disease either do not vasodilate or vasoconstrict. And, I think the LAD is severe here, but it's always interesting, and I'm never surprised if somebody comes back at another time when they are no longer under metabolically deranged circumstances and with multiple vasoactive agents. I've seen critical disease be moderate, and bridges appear less substantial. And by the way, severe diffuse disease vessels that quote unquote don't appear to be bypassable all of a sudden with resolution of that milieu, go back to the normal state and see that in fact they are bypassable. So I would encourage everybody, if you're cathing somebody who is in extremis and you see horrible small coronaries and you think that they're not treatable, if the patient improves, to recath them and reassess whether off of vasoactive agents, normalization of lactates, PO2. Sometimes you're pleasantly surprised.
Yeah, those
Do
are all.
you enter left ventricle and measure for left ventricle end diastolic pressure?
We did do that. I have a slide and a couple of slides where I have those numbers for you. Here's another look at the left main, a little bit of disease in the left circumflex artery, and then the right coronary artery. So it looks like there's probably some ostial right coronary artery stenosis here. Maybe about 60 to 70% in the prox-to-mid and mid RCA, which again is similarly diffusely diseased. Here's an RAO projection of that same territory.
Extensive atherosclerosis, but no culprit lesion for what we see.
So we have a 65-year-old patient who was recently in the operating room and just had brain surgery. The neurosurgical team emergently closed the scalp, and we were kind of faced with this decision, in the setting of a person who's in cardiogenic shock with a 12-lead ECG that looks like global ischemia. And this angiogram, we're faced with the decision on whether or not we should stent. And so we're really scratching our heads to figure out, is any one of these lesions a particular culprit? Were we missing something? And if we were to stent, what should we prioritize?
So for the audience, can you indicate a thumbs up or a thumbs down on your reaction? Thumbs up for people who would proceed with coronary revascularization. Damras, you would?
Yes, but it's the matter of the antiplatelet and all the bleeding tendency related to neurosurgery. I don't know that what's their plan and what they suggest after they close the scalp for cerebral artery clipping. I guess there should be small bleeding or no bleeding at all. If you give antiplatelet, I mean more or less intravenous form.
Yeah, so we did ask the neurosurgical team before we took the patient out of the operating room if giving heparin for the procedure and antiplatelet therapy would be a viable option if it were to be required. And they said, it's obviously not zero risk, but on the spectrum of things that they do, the aneurysm had been sufficiently clipped with a temporary clip. The scalp had been, although emergently closed, it was closed and there was no active bleeding. So they were okay with heparin and dual antiplatelet therapy if it were to be needed.
And what does temporary clip mean? What does that mean in terms of having to come back for definitive, Coulter?
My understanding is I don't really honestly know the specifics, but they had been rushed, and so they put in a temporary clip with a plan to come back and remove that clip without necessarily replacing it. So I think the plan was for that aneurysm to kind of be occluded off, if you will.
I see. Okay.
I think they're bringing the patient back to the operating room at a different date.
So what did you all do?
I was really reluctant to jump onto stenting this. I thought that in the setting of recent neurosurgery and the higher than typical risk of bleeding without a clear culprit, we should defer percutaneous intervention at this point in time and try to get some more information. And so it was already brought up, get an LVEDP. So we did do that. The LVEDP was 32 millimeters mercury, so severely elevated. We got the LV pressures with a pullback. And what you can see here, this first rhythm strip on the top is the left ventricular pressures and then pullback. And you can see the systolic LV pressure, the peak pressure is about 100, and then it drops down to about 55 or so in the aorta with pullback. The mean RA pressure at the time was 16. That's after about 7 liters of fluid. The PA pressure mean of 36, and the wedge was 34, so consistent with the LVDP that we had got. And the second waveform that you're seeing on the screen right now is the wedge pressure. And so the wedge pressure had V waves up to about 50 millimeters of mercury and average pulmonary capillary wedge pressure of 34. The pulmonary vascular resistance was 0.9, and I believe the cardiac output that we had calculated was about 2, if I remember correctly. No, it was 3.0.
So it's fascinating.
Yeah.
Because Damaris, I agreed with you. I mean, we don't have all the images, but that posterior leaflet looked a little funny to me. And yet this doesn't necessarily have a bifid appearance to the aortic contour, but that aortic contour is almost no pulse pressure. And there is a gradient here. And I think, what catheter were you using for pullback?
It was a JR4, 5 French JR4 diagnostic catheter.
So the one thing that, people taught me in assessing gradients are ideally one uses a pigtail catheter that only has a single end hole, because catheter entrapment in a hyperdynamic LV can result in the catheter catching in the trabeculae and giving an artificially high LV tracing. And I'm blanking on the name at the moment that was described. There's a particular term when you measure pressure within the trabeculae that will come out higher than that. And so ideally a pigtail single or a catheter that includes a couple of side holes at the distal end to catheter entrapment. And so this is suggestive, but because it's an R4, you can't exclude that it was riding along the trabeculae and having a degree of catheter entrapment.
But actually, I noted from your echo, previous echo, that the septum is very, very thick compared to the other part of the left ventricle. And second, because you have Judkin catheter in, I will introduce 0.25 Y into the Judkin catheter to make sure that the Y is in the lumen, and then pull back the Judkins through the Y, and then they will prevent from nicking into the wall, as Dr. Siguro mentioned. 0.0255 Y could be appropriate.
That's a great tip and trick, Damaris. I've never done that in the hemodynamic assessment of patients with known HCM that I do, as I use these different. But I'll remember that in the bag of tricks. So thank you.
Yeah, that's a really good point. There was one case that I did with Dr. Czar here last summer, and we were assessing subvalvular stenosis, and we put a safari wire in the left ventricle and put a multi-purpose catheter over the safari wire, and we were able to slowly come back to get a little bit better control of where the catheter was in time and space and do a slow pullback across the subvalvular membrane in the aorta, and so that gave us a little bit more control as well. So that was an interesting case. Yeah, that's a very good point.
So you're in a bind. You have persistent hemodynamic embarrassment, an outflow gradient, a patient that's not responsive to the typical things of increasing afterload and volume status, and a component of presumed dynamic outflow related mitral regurgitation, and an LV that's hyperdynamic.
I will do more DC synchronization, try to bring in normal sinus rhythm because you have all information here. I will go to the higher, the joules.
Yeah, that's a good point. So yeah, we were in a little bit of a hard spot here. So essentially our thought was, well, if the ECG is calling this global ischemia and we're not committing to a PCI and there's severe MR, potentially we could put in a balloon pump and that might help. Understanding that if there is this LVOT obstruction, that could potentially make it worse, but not really having a better plan, we put in a balloon pump.
So there are really only two options, Coulter. If you made a diagnosis of HCM and consequent acute severe MR and hemodynamic embarrassment not responsive to the pharmacologic maneuvers, it's a tandem heart. An LV support device will not work. This LV is too small.
Yep.
And you'll get suction and VT.
Yep.
And so it's interesting to think about the physiology of a balloon pump in a patient with HCM and consequent severe MR versus unloading the LA with a tandem and then reintroducing that via the arterial circulation. For the record, folks, we don't have tandem heart at OHSU. We utilize right-sided support devices like RV Impella and Protect Duo and ECMO and balloon pumps, along with left-sided Impellas. But Impella's out of the question here.
Yep.
Now I see more clear on the mitral morphology. There's obviously something in the tip of the mitral valve, maybe prolapse, a malcoaptation, or even a rupture.
Yeah, let me see if I can.
Yeah, there appears to be something flickering to my eye.
Yep. And so we were able to get a transesophageal echo that we repeated in the cath lab. This was done with our cardiology team. And it looked as though, and this was after the balloon pump was in by the time we were able to get the TEE probe in, but it looked like maybe there was a little bit of chordal SAM, so systolic anterior motion of the mitral leaflet. And there was a little bit of redundancy of the chordae there. We were getting pressure gradients in the lab of up to 55 millimeters of mercury. So we didn't heparinize the patient. So we went right femoral artery for the diagnostics. No heparin was given. We put the balloon pump in and left it on 1-to-1 so that we wouldn't necessarily have to heparinize the patient. And after we got these images that suggested perhaps there was some chordal systolic anterior motion of the mitral leaflet, we made a few changes. So our diagnosis at this point, our leading diagnosis, was obstructive shock due to left ventricular outflow tract obstruction as a result of chordal SAM, and this was a setting of hyperdynamic left ventricular function. So I mentioned that the patient was on norepinephrine, epinephrine, and vasopressin at the time. So we had transferred them to the cardiac cath lab. And before we transfer the patient to the cardiovascular ICU, we actually started weaning off of the current vasoactive medications, and we started phenylephrine and esmolol. We also
Just a couple of points, Coulter, is typically in the setting of HCM and SAM, the jet is almost always a posterior jet, not universally, but whenever you see posterior jets in this circumstance, that certainly is consistent with MR secondary to SAM. And if you see anterior, really look and make sure that there's not other abnormalities in the chordal apparatus concomitant with HCM.
Yeah, that's a good point. I didn't, I thought I had included it, but I must have omitted that. But they did a sweep of the mitral valve, and it did show that there was a posterior eccentricity to the MR. It was severe, and so the images that you saw were kind of the most impressive of the color Doppler. But if on sweep of the mitral valve, there was a posterior direction to it.
Yeah, and I've been sent patients for alcohol septal ablation to improve MR, only to note that the MR was anterior and that patient was one of the 15 or 20% of people who have anatomic abnormalities of the subchordal apparatus.
Oh. Alcohol septal ablation, probably not so effective there.
No. Justin, do you have a question or comment? I see your hand up.
When is the appropriate time for alcohol septal ablation in this particular case? 1 week, 2 weeks, or until the hemodynamic was stable and balloon pump was off?
I think, and Coulter may be presenting this, but one, in the acute setting, if the patient does not approve, and that is the etiology, but always first increase afterload and make those appropriate changes. And two, we would follow the same things as we would in a typical practice, and that is alcohol septal ablation should be second line to patients who do not respond to medical therapy. My own practice, we're a heavy mavacamten site, and so my alcohol septal ablations have gone from 15 or 20 a year down to, 3 to 7 a year.
Yeah, me too. 15 or 20 years ago, we have Dr. Jaranjit Raihal from Cleveland, from Mayo Clinic, to do the septal ablation during our AICT meeting in Bangkok, 2006. Jaranjit Raihal.
And so with those changes, coming off of the norepinephrine, epinephrine, and vasopressin, initiating phenylephrine and esmolol, and starting amiodarone, the patient was transferred to the cardiovascular ICU. And then within a few hours, the patient converted back to normal sinus rhythm, and the hemodynamics drastically improved. They essentially normalized, and the patient was able to come off all vasoactive agents. So at that point, it was clear that the balloon pump was more likely harming the patient than helping the patient, or at least not providing any benefit at the time. And so the balloon pump was removed soon thereafter.
And do you think the balloon pump helped at all at any point?
I honestly don't think that it did. I felt like the balloon pump, putting it in when we did, was it made me feel better that we were doing something, since I was able to. I talked my attending out of not doing a stent, but then felt committed to to, to doing something. So we put the balloon pump in. I don't think it was necessarily helping much in this particular situation, but I don't think it was necessarily hurting on all of the vasoactive agents that they were on at the time. But as soon as the patient converted to normal sinus rhythm and it was apparent that it was not needed, we took it out as soon as we could.
You felt it
Yeah.
was not unreasonable to put it in, although
Exactly.
whether
Yeah.
lowering the afterload further augmented the MR or not, who knows?
Exactly.
Yeah. Retrospectively, when you show your echo and MR and hypercontractility and very thick septum, I would do all means to convert the AF to sinus rhythm. I mean, go to 360 joules, try to convert the AF, especially if you are in cath lab. In cath lab, you have everything. Everything on hand can help you.
Yeah, I totally agree. That in the moment I wasn't confident that being on the highest doses of norepinephrine, epinephrine, and vasopressin was um, going to allow cardioversion to be successful, or if it was, be a sustained solution. But once the once the patient came off those, she converted on her own, which was convenient.
Yeah, that's true with us. We try to improve the hemodynamic by increase the dosage of vessel pressure. But when you see echo, good contraction, thick LV, do the cardioversion.
Yeah, that's a good point. The LV was functioning well at the time, so a little more energy might not have been the worst decision at the moment.
Yeah, this is a fascinating sequence of events, and I think it illustrates the chaos that happens in an operating room when hemodynamic instability occurs and persists. And it's never easy to walk into an operating room with an open skull and rapidly assess the patient and begin to implement changes. I think this was a ideal sequence to utilize in this case acute echocardiography, whether it's via the chest through standard transthoracic or TEE. And it's a reminder of how the ECG reflects ischemia, but didn't necessarily reflect the etiology of the ischemia. And as we thought about, epicardial coronary disease probably present, but what was the precipitant of the hemodynamic embarrassment was unknown at the beginning. And slowly you piece it together. It was not a vessel occlusion. And, the choices of vasoactive agents, which at the time appeared reasonable, were not necessarily, with the retroscope, things that helped.
Before you move to next case, may I ask one stupid question?
There are no
I don't
stupid
know.
questions.
Yeah. Do you normally do preoperative evaluation before cerebral artery clipping?
Yeah, that's a good question. So my understanding is that for most patients, the vast majority of patients here at OHSU who get surgery on an elective basis go through the preoperative clinic and they do a basic screening for functional status, and baseline ECG, routine screening, but it's not everyone gets an echocardiogram unless there's a red flag. This person was living independently, and had no functional limitations, no chest pain.
Yeah, and that's a great question, Damros, and I think that varies institution to institution at what the normal workflow is. And certainly we are involved for, and I'll talk about the outpatient environment, patients who are identified as having significant valvular heart disease, especially AS, which remains a challenge of how you manage a high risk or intermediate risk non-cardiac operation in the setting of AS. Interestingly, I don't know if you have seen the new ACC AHA perioperative guidelines that were issued this past year. But for the world that most of us live in, and that is patients with chronic stable coronary disease, for patients without acute coronary syndrome or without left main disease, the guidelines now indicate class 3 harm for elective PCI in patients who are undergoing non-cardiac surgery within the next 30 days due to higher MACE rates, and recommend proceeding with operation and then dealing with the consequences of said patient, should they develop ischemia. And Coulter and I just dealt with that 2 weeks ago, both in a preoperative consult of a patient transferred, and then postoperatively the patient developed AFib and then had a type 2 non-STEMI, and then we stented the patient. But it's class 3 harm now if they're having a procedure done in the next 30 days for chronic stable disease. Even ProxLAD.
Yeah, thank you. Well accepted that.
Yeah. Thanks everyone and participating with that case. So that was a fun one. This one's a little bit more straightforward, so I won't take up too much of your time. Case 2 is a case of a 75-year-old female former smoker with obesity and a BMI of 42. She has hypertension, hyperlipidemia. She presented to a rural hospital on the Oregon coast, a few hours away from OHSU, found to have NSTEMI. So from the emergency department on the coast, she was transferred to a nearby hospital that had a cardiac cath lab, and she underwent a coronary angiogram there. This is the right coronary artery. It's a large dominant vessel. You can see there's some moderate mid RCA stenosis, but it provides TIMI3 flow to the PDA and PL branches. Here's an AP cranial projection of the same vessel and an RAO projection. Here is a LAO projection of the left coronary system. So you can see that, the left main is a moderate caliper vessel. And this projection here, it seems as though there are two eccentric stenoses in the mid segment and distal segment of the left main, potentially some ectasia near the bifurcation of the left main and left circumflex. We'll see that in a different view. And then the left anterior descending has TIMI3 flow throughout, but a moderate to severe diffuse disease. This is a little bit different projection here. You can see the eccentric left main stenosis in the proximal and distal segments. The distal left main appears to be about 95% stenosed. Then the left circumflex is a small non-dominant vessel, gives rise to a small atrioventricular groove circ and a small M1 and a moderate OM2, which is a kind of a narrow caliper vessel with subtotal occlusion in its proximal segment. Here's another projection that shows you kind of the diffuse LAD disease. Here you can see a little bit more of the ostial to proximal LAD disease right before that moderate sized diagonal branch. which itself is severely stenotic at the ostium.
That is a very ugly disease, very
Yeah.
ugly.
BMI
Yeah.
42.
Yep. And so the team there did get a LVEDP, which was about 35 at the time of the cath. She was diuresed at the hospital and underwent evaluation for revascularization options at that hospital. Her case was reviewed by the local cardiac surgery team, who determined that the patient was too high risk for coronary artery bypass grafting. This was primarily due to her limited baseline functional capacity. She lived in a small home alone on the Oregon coast. This is a picture probably about 20-minute drive from her home. And so she really didn't have a lot of social support, lived on her own, and really was limited to ambulation within her house. So because she was considered to be too high risk for surgery at that hospital, she was referred to OHSU for a heart team discussion to determine the best revascularization strategy for her. Does anyone have any questions or thoughts about her case so far?
I think given the time, let's just show them what we did and kind of a brief why.
Okay. So this is her ECG sinus rhythm. It looks like maybe there's some anterior Q waves. Creatinine was normal, hemoglobin platelets normal. Her high sensitivity cardiac troponin was just over 1,000 and stable when she arrived here at OHSU. Her left ventricular size was normal, but she did have a moderately reduced left ventricular function of 35 to 40% with hypokinesis in the LAD territory. There was no LV thrombus, her RV was normal, and there were no significant valvular abnormalities. So our surgical team felt that she did have a target for a lima to LAD, but the OM vessel that was subtotally occluded was too small of a caliber vessel to be able to sufficiently bypass. And due to her poor functional status and high STS risk, it was felt that she would benefit more from left main PCI into the LAD. So we elected to do a femoral approach. This is her angiogram. And we elected to do an Impella-assisted PCI of the left main and LAD. So this case was single access approach. So the standard 14 French Impella peel away sheath, and adjacent to the drive line through the diaphragm, we put the 7 French companion sheath that comes with the Impella kit, and used an XB 35 guide catheter and a BHW guide wire that was advanced into the LAD. We pre-dilated the lesion with a 275 non-compliant balloon. And this was the post pre-dilation angiogram. It showed that the lesion at least partially yielded. And then we did an IVUS. So this is from the mid LAD back into the left main. You can see the vessel is diffusely diseased. There's an eccentric plaque. As we come back into the mid, nearing the proximal LAD, here you start to see some calcium, which becomes more than, about, this is at least 180 degrees of calcium. The measurements there, the diameter was 3.0 by 3.8. And then coming back into the left main here, you see another severe eccentric stenosis that is heavily calcified.
I just want to comment, if you go back to the balloon inflation, it looks like in the distal left main that balloon was fully expanded. But as you saw here, the calcium ring remained intact in the distal left main. And there was only one little area at about 4 o'clock to 5 o'clock that was fractured in the prox LAD. And so this would be, to me, stent regret with a napkin ring in the distal left main lesion if we had proceeded after that NC, not IVUS, and just put a stent in.
Yep, I agree. See. So because of the severe calcification with greater than 270-degree arc and at least 2 focal segments, we elected to perform further lesion modification with intravascular lithotripsy. So this balloon here is a 4.0 diameter by 12 shockwave balloon. We performed 8 independent inflations from the proximal LAD back into the left main coronary artery and administered 10 pulse treatments per inflation from the proximal LAD back into the left main coronary artery. So a total of 8 pulse treatments were administered. And we have just a
I see
couple.
much more eccentric cholectasia on the proximal LAD that we cannot see from IVUS.
Mhm.
But
Yeah,
from
it's,
angiogram, that's cholectasia.
yeah, it seems much more prominent on the angiogram than what we were able to appreciate with IVUS. I agree. So after we administered um, the intravascular lithotripsy shocks, we felt confident that we had modified the lesion enough to be able to deploy a stent. So this is a 4.0 by 18 drug-eluting stent. And the goal was to try to land the proximal stent right at the ostium of the left main coronary artery.
Before you show your stent implantation, would you go back to your initial IVUS at the point of the bifurcation? Because when you see the IVUS at the left main bifurcation, you see the Y on the side branch, and there was exactly calcium at the opening. Yeah, here. If you go back slowly a little bit, you can see that calcium is on that side.
Mm-hmm. Yeah, yeah,
that will be close
sure.
on the side branch. Yeah,
Mm-hmm.
very
Yep, so,
severe, very
yeah.
heavy calcify at the bifurcation.
Mm-hmm. Yep. Yeah, it's definitely, I find one of the challenges with IVUS is you get the calcium with the shadowing, and so as the calcium um, changes planes, you get that shadowing. It's very hard to see the true ostium. You can see it rotating from the 2 o'clock position to the 11 o'clock position here, and then you can see the opening of the circumflex here, and that calcium tends to go, it appears to be going into the circumflex artery. So it's hard to tell exactly how much obstruction that calcium is actually causing. So another option, you could wire into the left circumflex artery and IVUS that blood vessel independently.
In IVUS picture like this, I prefer to stent technique because of the calcium is the obstacle when you try to wire the side branch when you deploy the main branch stenting.
Yeah.
No, great points. I thought that the os of the circ had enough of an opening, and the left main plaque was primarily adjacent and would likely not shift, but it was a gamble, Dammers.
Mm.
And then we went to that LAO 35 with about 15 of cranial to figure out the true os, so we could position the very proximal segment of the stent.
Yep.
And that's my favorite view, something in that 30 to 40, 10 to 15 cranial to figure out where to place the proximal segment of the stent relative to the ostium.
And
So we're going to just adjust it so that the superior segment of the left main is covered. A little bit of the inferior stent will be just outside of the os.
Yeah, that's was very interesting.
So this is the stent expansion here. And this was our final angiography. So I didn't include the full angiogram, but there's TIMI 3 flow to the distal LAD and distal left circumflex, and our post PCI angiogram. But this is kind of the best look at the left main into the proximal LAD. And this is our post PCI IVUS image. Here we can see that the stent is well opposed, well expanded. This is through the proximal LAD. And then you can see as we pull back, there's a little bit of under expansion here from heavy calcification. And then back into the left main right before the ostium is where the proximal stent landed. I apologize, I didn't include the measurements on here. I can't remember them offhand, but we felt that despite this little bit of under expansion here, further post dilation with that much calcium would be greater risk to the patient without additional benefit, given that the minimal stent area, it was, I can't remember the exact number, but it was sufficient.
So do you do a pot?
This one we did not pot, I don't believe so.
Not in the ostium where it was well opposed, and I didn't want to perforate in that distal left main. We had already hit it with IVL and high pressure NC ballooning. And I thought that the proximal segment of the stent was, opposed. So I didn't think I would get much more in terms of the ostium of the stent or in the shaft where we had already gone, really hard with IVL and NC.
It may be a negative remodeling at the very distal left main, negative remodeling that caused the restriction of the vessel.
So, I thought this was a nice case that illustrated a couple of things. One, the importance of mechanical circular support, because even with the use of Impella, our pulse pressure during IVL decreased substantially. Second, don't get fooled by an NC balloon that appears to be fully inflated, and use IVUS, and then plaque modify, repeat IVUS, and then make the call on the cross-sectional area and under expansion as to how aggressive you will be with your NC. And she did well. Impella was removed, unfortunately, manually, as our per closes failed.
Yep.
Both are great cases.
Yeah, thank you all for taking the time to walk through those with us. That was fun.
Thank you very
As
much.
you mentioned that she lived in the rural area, will you supply the patient with the 12-month DAPT at the same time? Because she might not come back to see you again.
Yep, she's fortunately she's a patient with the VA, and she has a VA clinic not too far from her home, so that she at least has some resources out there.
What was the picture?
We have problem that in Thailand where patients are living in the remote area, and interventionists perform stenting and supply only 2 weeks of
Oh, no.
the clinic. And then they don't take medicine and then send thrombosis.
Yep.
Well, I hope that that you all enjoyed the cases. The first one was ischemia from acute MR and hemodynamic embarrassment from HCM that uncovered chronic disease. And the second was, just a fun case to work through with IVL and Impella.
Very
Thank
well
you,
presented.
Prof.
Thank you, Culture,
These
too.
two cases are excellent, Dr. Sigarwa, Dr. Coulter. Thank you very much. Excellent.
Thank you.
Wonderful seeing you all as always.
Thank you
Monica,
so
I'm
much.
sorry I didn't hear you.
Thank
So
you.
Thank you.
thank
you.
you, everyone.
Excellent. Excellent.
Thank you.
Good to see you
Coulter,
all.
thank
Thank you,
you so
Damras.
much.
Thank you.
Thank you, Wanapa.
Thank
Ciao,
you.
everybody.
Thank
Bye,
you.
Austin.
Bye, Joaquin.
Bye-bye. Bye-bye.